The year is wrapping up, and we'd like to go out on a bang, and we talk about today's topic, which would be pregnant people with substance use disorders, a whirlwind overview of important things I think you should know. And our speaker today is an invited speaker, Dr. Smid. Is a board-certified maternal fetal medicine and addiction medicine physician at the University of Utah. She's been a member of the Utah Perinatal Mortality Committee since 2016. She's the medical director of substance use and pregnancy recovery, addiction, dependence, super rad.
Way easier to just say super rad.
Super rad, okay. And especially perinatal clinic and multidisciplinary clinic for pregnant and postpartum women with substance use disorders. Her research focuses on perinatal addiction, interventions for pregnant people and postpartum women with substance use disorders, maternal mortality, and maternal mental health. And so I'd love to turn it over to her. Just a little housekeeping as we're getting geared up. The CME number will be dropped into the chat, but for those listening, it's CME number 926-510, and you text that to number 866-327-3062. And I will hand it over.
Hey, thanks so much for having me. Really appreciate being here. Thanks for the invite. Like I mentioned, am a maternal fetal medicine and addiction medicine board specialized. And for my friend, Holly Bullock, who is on this, I have lost my mind and decided to take complex family planning boards. So TBD if I get another line added to this board certification. So I am going to do a very broad overview. If someone could monitor the chat for me, I tend to think it works a little bit better if, because especially in the virtual world, we're all getting pulled into 9 million places. So by the time we get to the end, particularly the residents, even though they're supposed to have protected time, we all know that you get paged to go do other things. So if you have questions, please put them in the chat or unmute and just ask the questions, because if you have a question, somebody else has that question as well.
And I'll monitor your chat for you.
Thank you. So these are my disclosures. The most important one is I'm anti-Calibri, which for some reason I feel like is just super important to talk about. Okay, so these are the things that we're going to talk about. I think it's important because addiction medicine is, as most of you know, fairly new, and it's particularly new to many OBGYNs. So I know some of the OBGYNs are going to be on. It's a new board specialization, and there's a bunch of different pathways to getting into this work. So I'm going to take you on a very quick tour of how I got here. And then we'll get into meat of things, and we'll talk about understanding perinatal addiction, particularly, and I think, I really am targeting this at the residents and our learners here, that using non-stigmatizing language. If you can take one thing away from this lecture and changing something that concretely that you do is examining the way in which you talk about people with addiction and the way that you chart about them, the way that you talk about them in the medical record really does have an impact on the way that people see themselves and the care that they receive. And then we'll talk about the trajectory of substance use and substance use disorders and how it intersects with pregnancy and the postpartum period, including bolded the increased risk of death, right? So you are 20 people logged on here, a lot. This is a life-threatening condition that we really need to be paying attention to, particularly in pregnant and postpartum people, because they have additional risk. And then we'll get to hopefully talking about the evidence base and then what I like to term evidence-informed treatments for substance use disorders in this population. And the reason I use evidence-informed is that much like most things in obstetrics, we use a lot, we extrapolate a lot, and we make a lot of decisions based often on one study, which if you're in internal, you come from the internal medicine world, you have to have like 20 enormous RCTs to make a decision. And that just does not happen in the world of perinatal anything, particularly in the world where perinatal meets addiction. So who is this person and why is she here to talk to me? So I'm an OB, and a lot of times folks put their pictures of their babies on there, but I am very maternal centric. So I now include a picture of my mom. So that's my mom and me as a baby. And I was not born thinking that I was going to do perinatal addiction. So how did I get here? So this is the person that is pictured here is Jasmine Charles. She is a PA and my clinical director for the Super Ad Clinic. And that is us celebrating the Super Ad's first birthday. But I did not even get recruited to the University of Utah, which was now almost 7 years ago, thinking I was going to do this. So I did medical anthropology when I was an undergrad, and I did a master's at Case Western Reserve in Cleveland. I did a lot of it was on birth. And so that kind of set me up for a lot of moving into addiction. And then I was at the joint medical program between Berkeley and UCSF and did another master's on pregnancy decision-making among homeless youth, which was a real introduction into the intersection of how addiction played in the intersection of pregnancy in that population. And then I couldn't figure out if I wanted to do triple board or OB or family. And so I took a year off and went and studied traditional parteras and midwives in Mexico. And then I did an OB/GYN residency at the University of Chicago, where I received exactly 0 formal lectures or training on addiction during my entire residency. We certainly had individuals with addiction. Cocaine use disorder was quite prevalent on the south side of Chicago. However, I don't remember a single lecture, and I think that's, you know, if I were to survey my cohort of individuals, I think that that's pretty common, very uncommon to have gotten any formalized training. And then I did my MFM fellowship at UNC, and I really focused on obesity and bariatric surgery. As part of our fellowship, though, I was required to get an X waiver, and so that was really the foray that I had into addiction. And we took care of the Horizons program, is another integrated care model that at UNC, and the way that we used to do antepartum initiations onto buprenorphine or onto methadone was really what I knew, and I brought it with me. I mean, I for a while had the exact protocol taped up with the UNC logo here at Utah, because there was no model when I got here. So I got recruited here to be a clinician scientist, and thought that I was really going to focus on pregnancy after bariatric surgery. And the head of the division of bariatric surgery is still one of my closest friends, but I really have moved away from that, because my clinic became kind of the opioid use disorder clinic, because I was the only person in the entire department that had an X waiver. And so now that's not as relevant. That's very, very, very recent. And then about a year being here, I decided that I wanted to, if I was going to take this on, I really needed help, because I was at my brother's wedding and I was getting panicked phone calls because nobody else could write for buprenorphine. So then enter Jasmine, who had just joined the faculty as a APC, and we kind of took this on, and we had an addiction fellow and us and 2 MAs and a volunteer, an undergrad volunteer with a program called Connect to Health, who helps to connect with WIC and housing vouchers and those types of things. So people ask, what grants did you have? We had none. How did you get into this? We kind of moved towards it because there was no one else taking care of these folks. And then because I was research faculty, I really shifted both my clinical work and research to this area. And then I did the addiction medicine clinical pathway board certification. So I think that's still open. It's going to be open for a couple more years for addiction medicine. And it is open to OB/GYNs as long as you are doing at least some portion of your care as in addiction medicine. So that's how I got to here. Okay, so we're going to go over what I have learned. It's not going to be perfect, but that is okay. So now we're going to move into perinatal addiction, and I'm going to start with words. I think really breaking down how we talk about addiction is really important. And if you come away with nothing else from this lecture but the ability to use the correct terminology, I will have done my job. So when I refer to substance use, what I mean is sporadic consumption, which is of substances that are generally without adverse consequences. So that is generally, because there may be adverse consequences that are short-term or long-term, but it is a almost ubiquitous experience among humans and really among mammals. Mammals really like to use substances, and humans particularly like to use substances. And misuse is the term that's really about excessive use of those psychoactive substances, including any and all of these things that could lead to physical, social, or emotional harm. So most people who have engaged in any kind of substance use have also, at least at some point, engaged in misuse. And when misuse is repetitive, that's where there's a term that is not on the slide, but is starting to be used, called pre-addiction, kind of like we think about pre-diabetes. So you don't have overt diabetes yet, but a pattern of continued misuse, and particularly with that potential to lead to physical, social, and emotional harm, can really be a setup for pre-addiction. So tolerance, physical dependence, and psychological dependence, often these terms get used interchangeably, but they are not the same. So tolerance is the physiological adaptation and diminished responses for substances after repeated uses of that substance. And physical dependence is when we take away that class of medications, then we're really getting those abrupt cessation or rapid dose reduction of the substance by administration or by the administration of an antagonist. So that's, for example, somebody is taking opioids, they've developed a tolerance to it, and then they try by themselves, or they run out of their prescription or what have you, then they will have those withdrawal symptoms. And that is not the same thing as addiction, and we'll get to how those are a little bit different. And psychological dependence is that subjective feeling like you need a specific psychoactive substance, either for its positive effect or avoid the negative effects associated with its abstinence. Okay. And so what is addiction? So addiction is really the primary chronic disease of the brain. It's of the reward, motivation, memory, and related circuitry. And when we see a dysfunction in these circuits, we tend to see these characteristic biological, psychological, social, and spiritual manifestations. And it's really reflected in an individual's pathologic pursuing of reward or relief by substance or other behaviors. And that is a really important distinction to make. So substance use in a person that does not have an addiction is a choice. However, substance use in a person with an addiction is generally the symptom of the condition, because it is pathological. It is really pursuing that substance use because either you're seeking that I want to feel good, or often more importantly, particularly in people who have more severe disease, it's just about not feeling bad. And so it's not a moral failure. There are real changes in the brain that we can see. And on my boards, if any of you, so those of you who are doing addiction medicine or psychiatry fellowships will soon be taking the boards. There was a question that was 50%, and I used to have this say 50% of addiction is genetic. And it's really 50% of addiction is likely hereditary or familial. And we're not actually sure. There is likely a genetic component to it, but it's probably more complicated than that. And it could be genetic, it could be epigenetic, which is really important in the perinatal field. It can certainly be environmental in that family that you were raised in. And it can be compounded by when you have a genetic component, and if you're being raised with people who have an addiction. And so those are really important things to tease out. And the reason that there's a picture of diabetes up there is that if you take the pedigree of somebody with diabetes and you take the pedigree of somebody that has addiction in their family, often they look about the same. I mean, you see them going back in generations. It may not be the same substance, but you can see generations going back that there is presence of individuals with addictions. And so those of you that are old enough to remember Nancy Reagan's say no to drugs commercial, right? It's not Nancy Reagan's brain. People with addiction really we can see on imaging that there are changes in the brain structures that happen as addiction develops. And it's really about being motivated less by feeling good and more about not feeling bad. And so then substance use disorder, the difference between addiction and substance use disorder, which I will use interchangeably in this talk, but substance use disorder is the way we make the diagnosis. So addiction is kind of the state, and then substance use disorder is the DSM criteria by which we make the diagnosis. And so you have to have and it really replaces, so before we get to how you make the diagnosis, this term I invite you to replace, if you are using words like substance abuse, to really replace that with substance use disorder. Substance abuse is a very, very stigmatizing and judgmental term that has previously been used and is really an outdated term. So we want to be using substance use disorder. And then dependence, which I still use because often individuals with chronic pain will have dependence, and we need to take care of those individuals in our clinic. But that's really what that older term refers to. And so to make the diagnosis, you need to have 2 or more of the symptoms that are listed here in the past year, and it is underlying resulting in distress or impairment. So this has to be distressing or impairing the individual who is in their daily activities. And it can't just be in that physiology. It can't just be tolerance or withdrawal. So I mentioned individuals with chronic pain. There are many conditions that are managed with opioids, and a person who is on long-term opioids will develop tolerance and they will have withdrawal if the opioids are taken away or they don't use it in an appropriate amount of time. And that doesn't mean that they have a disorder. So there are many, many people who fall into the category of having tolerance and will experience withdrawals, but it doesn't mean that they have a substance use disorder. It has to be distressing, or there has to be impairment of activities. So something in loss of control and something in that consequences category. So this is very quickly just the neurobiology of addiction. We're not going to spend a bunch of time on this, but I will just point you to the reward and reinforcement, nuclear accumbens, and ventral tegmentum. That's where dopamine and oxytocin happen. Salence and fear is really controlled by the amygdala and executive functioning. That's in the ventral prefrontal cortex, and where we see the preoccupation with the use of the substance with behaviors that are associated with its use. So this is a talk about pregnancy, and I've barely talked about pregnancy. So this slide is really to talk about what happens to an individual's brain when they are pregnant or in the postpartum period. And the thing that I will just draw you to is that lots of the areas of the brain, including the amygdala and the prefrontal cortex, are affected by pregnancy. So pregnancy brain is a very real thing. And when pregnancy and addiction meet, we're still sorting out what happens in the brain exactly, but those parts of the brain are both affected by addiction and by pregnancy in the postpartum period. And so this is just another slide. And this is where I am mostly selfish, because it really just reinforces my experience of pregnancy brain. So important slide. Infants cannot have addiction. They cannot. They do not have the changes in their circuitry, in their neural circuitry, and they cannot have distressing or impairment or pathological pursuing of a substance. So that, remember, is the definition of an addiction. So addicted birth or addicted babies, right? This is what happens to my brain when I hear those terms. So infants can certainly develop neonatal abstinence syndrome or neonatal opioid withdrawal symptom. They can have tolerance because they may have prenatal exposure. They may be affected by substances in utero. They may have physical withdrawal symptoms characterized in this slide. It's really around, I'm focusing on NOWS, the opioid withdrawal syndrome. But these are self-limiting and treatable conditions that in and of themselves do not portend any sort of adverse events that may happen to an individual later in life. So what happens so I started this talk by saying, if you can do one thing, you can change the way or continue to use non-stigmatizing language if you already are doing that. And that's really around changing the process around stigma and discrimination. So stigma is the process that discriminates against people who, for example, use drugs, particularly pregnant and parenting people, and it pushes them to the margins. And there are several levels of stigma. And so an individual can experience stigma by using a stigmatizing word like addict or junkie, for example. Institutions do this by, for example, firing people for a positive drug screen. Stigma through association happens, for example, do we really want those people in our office? And then I would argue that internalized stigma is by far the worst. It's when people have internalize the messages that they are receiving, that you are a bad person if you have an addiction. So it's not that you're doing a bad thing, you are a bad person. And they believe that they deserve pain or suffering because they've used drugs, particularly if they are pregnant. And what we see is that people that are exposed to stigma also have brain changes. So we don't have studies yet that can tease apart what happens to brain changes with pregnancy, what happens to brain changes with addiction, what happens with stigma. But if you are looking at the brain of a person that has perinatal addiction, they for sure have experienced stigma. And we know that people who have experienced stigma have changes in their brain volume. So I challenge you, invite you to really use person-centered language in all of your medical practice, and particularly around substance use disorder. It is really important to allow people to label themselves. So if a person wants to refer to themselves as an addict, and that is a way that they use that term and reappropriate that term for themselves, that's entirely okay, and we don't need to correct people. But you, as particularly as medical professionals, should really be talking about and charting as person with a substance use disorder, person who uses behavior or who uses heroin. You want to describe the behavior or the condition, not the person by the disease. And I see this a lot. So I've absolutely started seeing that change happen. What I still see all the time, I mean, up and including this week, is talking about people who are clean and who are dirty. So the cord was clean, the Utox was clean, or they had a dirty urine. So what I challenge you to do is to get rid of that. Like, you can talk about your house that way, you can talk about your car that way. I talk about my child, whether she's dirty or not. But the point is that you don't want to talk about a person with substance use disorder as clean or dirty, because when you say clean, even if you don't mean to, you are implying that they are dirty or somehow less than when they are using. So that should just go away from your lexicon. And then, like I mentioned, addicted baby, newborn with exposure, newborn with opioid withdrawal, addicted babies or crack baby, which I haven't heard in a long time in a professional environment, but I'm sure still gets used a lot. And then medication for opioid use disorder. This is one that folks don't usually think of, but even saying things like MAT, so for OUD, I challenge you to use medication for opioid use disorder, because you would never refer to insulin as MAT. It's not medication-assisted treatment, it's just treatment. And so is buprenorphine and methadone. It's the treatment. It's the first-line life-saving treatment. And so when we say it's medication-assisted, we are implying that something else, often behavioral therapy, is somehow better than or the primary way that we treat it. It's really medications and behavioral therapy give us the best outcome, but medication in and of itself is the primary treatment. And then we can't talk about perinatal addiction without talking about racism and classism. So in this person-centered change that we've seen certainly over the last decade, is not uncoupled from the fact that opioid use disorder affects disproportionately white individuals. And cocaine use disorder that affected folks in the 1990s, primarily our Black and Brown individuals, were not afforded the same person-centered language. It was certainly talked about as a moral failing, and that children needed to be protected from their mothers who were monsters who were using cocaine and didn't care about their well-being. I think we are developing a more nuanced way of discussing this, but we need to acknowledge that racism and classism has existed historically and continues to exist in the ways in which and access to which people have access to perinatal addiction services. And then this slide that you see, the brain, the fuzzy brain, is to say that racism and by extension, classism also affects the brain. And so again, we're seeing brain changes that are happening for folks with perinatal addiction, and likely their experience of discrimination and stigma. Okay, so now I'm going to move into knowledge snacks about substance use and substance use disorder in the perinatal period. So the vast majority of pregnant individuals will achieve abstinence from a substance by the end of their second trimester. And most frequently, this is without medical intervention. And so Mishka Turpelin, if you've ever had the opportunity to hear him speak, and I would encourage you to do so if you're ever at a conference where he's speaking, says that it's really pathognomonic by the time you get to about 20 weeks. If somebody is using a substance, that is pathognomonic for a substance use disorder, because pregnant people know that it is not good for them or their baby. So if they're using by that second trimester, it is generally compulsive and is almost always distressing to them. And so really that, and people will try to hide that use because they know it is so highly stigmatized by society, but also because they understand that it's not ideal for their health and the health of their baby. But it doesn't mean that they don't have a substance use disorder. So just because you aren't using doesn't mean that those brain changes have gone away. And what we know is that 80% of individuals in the postpartum period who were abstinent in the last month of their pregnancy have a return to use of at least one substance in the year postpartum. And so this is, again, a great cohort study. It's really around nicotine, cocaine, cannabis products, and alcohol. Since this study doesn't include opioids, but we really see that same pattern across all substances. And so why do we see that? So this is really just a slide to talk about the sex and gender differences. This is a talk, but in and of itself is an hour-long talk. But we know that there are some sex differences. So men and women, women will have what's called telescoping phenomenon, where they have quicker initiation from first use to disorder than men. Women tend to have more chronic medical conditions, which may predispose them to, and those chronic medical conditions may predispose them to having that faster telescoping development. And then certainly gender roles impact some of the use patterns that we see. So particularly with methamphetamine use, which we have here in the West. I often ask our patients, why meth? What is it? Because people don't use drugs for no reason. And it's that they feel like they have to use it in order to take care of, and they may be in that sandwich role where they're taking care of either parents or elderly folks that are their grandparents, and then children. And then it's around really getting those things done. And then in the postpartum period, we've seen really weight loss be a huge trigger. So they're abstinent during the pregnancy. They often, if they have a severe use disorder, they're gaining weight because they may have been underweight or their appetite was suppressed when they were using. And then when they are able to be abstinent, they're gaining weight. And in that postpartum period, there's a huge trigger to return to use. And so these sex and gender interactions and gender relations really play a role in the way in which an individual who is pregnant or postpartum experiences development. And then this is something I'm really interested in the pregnancy. We see progesterone and estrogen go sky high. And then the reason you see a cliff jump over there is at that delivery, you lose that placenta, which is really the producer of progesterone and estrogen, and you really have a really low level of those sex hormones. And in both animal studies and in non-pregnant individuals, we see that estrogen can really impact dopamine signaling, and that higher levels of progesterone compared to estrogen are associated with less likely return to use and fewer cravings. And so it may be that it's this high level of progesterone in pregnancy, which is helping people achieve that abstinence, is that the part of their brain, that amygdala, that they sense those cravings, is really affected by that, and that they're not getting as much dopamine signaling because the estrogen was lower than the progesterone. And then that is kind of the opposite. The opposite occurs in that postpartum period, that you're really seeing low levels of estrogen and progesterone and a return of cravings. So now we're going to move into what substances do people use in pregnancy. So it's not an uncommon, people use substances in pregnancy. So we sort of think of this as the super rare thing that happens. It's not. Right, so about more than 1 in 10 pregnant individuals have reported past month illicit drug use or alcohol. And in the PRAM study, about 1 in 5 of pregnant individuals have received opioid prescription in pregnancy. And the primary reason, if you dig into that in that MMWR, you see that it's often for pain, And then if you dig even deeper, you can see that it's often pain that is really could describe the pain of pregnancy. And then this is a study that we did in Utah where we took umbilical cords. Essentially, it was an anonymous study. We didn't collect patient information, and we collected what people throw in the trash, right? So the placenta and the cord. Once we make a big deal about dad cutting the cord, we all cheer that he used his kindergarten skills. And then we took those cord segments and we analyzed them. And we actually have historical data. So this was done about 10 years ago with a slightly different assay. But what we're seeing, at least in Utah, is that we've seen an increase in the amount of cords that are positive for any substance, and most notably opioids, amphetamines, cannabis products across our state. And then this is a slide just to demonstrate again that we really see when we include nicotine, alcohol, cannabis, and illicit drugs, we really jump up to almost 1 in 20 and 1 in 5 individuals using a substance. And what I want to draw your attention to is we're going to focus a lot more on opioids and methamphetamines, because that's really what this talk is centered around. But it's nicotine and alcohol, which are the legal substances that are readily available to most adult individuals, that have both the strongest evidence of harm in pregnant and non-pregnant people, harm to a fetus, and really have causal relationships to adverse perinatal outcomes. The other substances, meth, cocaine, heroin, fentanyl, really don't have the same associated risk of low birth weight, congenital anomalies, stillbirth, preterm birth. It's really nicotine and alcohol. But we're here to talk about opioids. I'm gonna mostly focus on opioid use disorder and meth use disorder, but I want to at least couch it in that discussion. So we've seen certainly pregnancy complicated by opioid use disorder quadruple over the past 2 decades. And we've seen the same pattern happen for methamphetamine in pregnancy. And so in the West, and I think Arizona, you guys are seeing the same pattern as we are seeing here in Utah, is that we're seeing about 1% of our deliveries in the state be affected by methamphetamine. And that was actually captured in our cord study as well. We had about 1% of cords that were positive for methamphetamine. So these statistics are actually pretty spot on. What do we know about pregnancy and methamphetamine and really substance use in general is that it's often complicated by poor prenatal dating and poor pregnancy dating, because people are afraid to come in for prenatal care. They're often trying to stop using. I mentioned that sort of 20-week point that most people are able to achieve abstinence, that they're trying to stop using before they go into their first visit, so they don't need to, they're like, well, I'm not using, I'm good. And we know that alone, and that fear and that stigma may be some of the driver to preterm labor, intergrowth, fetal growth restriction, preterm labor. It may be the substance itself, but it may also be the stress of carrying, of knowing that you are using a substance and that you are really at risk of discrimination and stigma. And what we'll get to later is the fear of having your child taken away, which is just the question that everybody wants to know. And then I often get this, so we're gonna just talk about this real quick. Well, what about breastfeeding? So we really have extremely limited data about breastfeeding in any substance, really. This slide focuses on methamphetamines. The recommendation against breastfeeding during active use is really around infectious disease risk and acquisition, because of the way that substance use and the ways in which getting supplies to use the way that really reduces risk is difficult in our current state, in our current policies. There's an increased risk of acquisition of infectious disease. So once somebody's HIV, and it's really around HIV, comes back negative, then the argument is that one, if they've stopped using, their breast milk should clear by the time their urine is negative. Now, why? And this is really methamphetamine related, because cannabis is a little bit different. But what do we know that based on? This is based on a case report of 2 individuals in Thailand. And so really questions around heroin fentanyl, we really just have such limited data. But theoretically, once the urine has cleared, then really the breast milk will almost certainly be clear as well, which is that bottom line. And the breast milk concentration of methamphetamine, for example, is extremely low, even right after use. So I want to briefly mention cannabis because it is certainly one of the most quickly growing substance use disorders. So again, we have to distinguish between use and use disorder. Many pregnant individuals self-report using cannabis products. And if we really base it on urine toxicology, it goes up to about 19% of pregnant individuals 18 to 25. And that increase, we did see an increase with COVID. So we're all a little bit waiting with bated breath to see if the rates drop back down now that we're in the post-COVID period. And one of the important things is that individuals in Arizona, you are a legal state, that cannabis dispensaries are actually recommending cannabis products for nausea in the first trimester. What my colleague Tori Metz does a really great talk about this, which is the senior author on a paper where a resident and the investigative team called dispensaries and pretended to be a pregnant individual seeking advice. And only about 1 in 3 of the dispensaries that they called recommended that they talk to a clinician without first being prompted by the caller. And so really individuals may be getting, and that's why it's important to distinguish that substance use and substance use disorder, is that they may be getting messages that cannabis is better for you, it's safer for you, and we know the evidence is really mounting against that, and then especially with cannabis use in pregnancy, we're starting to see really robust signals for small for gestational age, preterm birth, stillbirth, and potentially neurobehavioral issues in childhood. So what does that mean? Certainly counseling around that cannabis use would not be considered safe. We don't know what is safe, but that we're seeing more and more studies that are being done and are attempting to control for confounding things like maternal mental health, poverty, some of the ways in which previous studies that are trying to understand that relationship between a certain substance and these adverse outcomes, controlling for those confounders. And so certainly this is and I'm happy to share these slides, is that breastfeeding, when you're having a conversation about either cannabis, and cannabis is specifically an interesting one because it's fat soluble, it's really lipophilic, that you want to balance, I don't think anyone thinks that we should be recommending cannabis use during lactation, but really weighing the risks and benefits, that we know that there are demonstrable breastfeeding benefits, but we don't know whether whether the presence of cannabis products in breast milk, really those risks outweigh the benefits. So it's really got to be patient-centered discussion. Okay, so now we're going to move into, and I'm also not very good at my own timekeeping. So I want you guys to somebody will probably have to give me some time warnings. So I said in the objectives that we were going to talk about death, because it's really an important conversation to have when we're talking about addiction and pregnancy. And so these are the waves that we've seen with opioids, and this is the wave that we're seeing with stimulants, and we're really seeing an increase in these dual pandemics. So you can't talk about methamphetamine without talking about Walter White, and certainly we used to talk about fentanyl as being more of an East Coast thing, and methamphetamine being more of a West Coast thing. That's totally out the door these days. So this is just methamphetamine rates across the country. What we're seeing is that we're seeing it all the way across the country, and we're seeing fentanyl all the way across the country. I suspect that your fentanyl rates look a whole lot like ours because of the supply pathways that are happening here in the West. And we're seeing overdose epidemic. We get still a lot of press around opioids and fentanyl, and the fentanyl now driving the opioid epidemic. The methamphetamine related deaths have also increased by 180%, and the largest increase has been among Native American men and We're also seeing much higher rates of methamphetamine use disorder among heterosexual women and 10 times the rate among Black individuals. So certainly in the West, Native American individuals are disproportionately affected by this increase. And so when we combine this opioid and stimulant overdose, why are we seeing that? And then and a little bit of what I'm going to say is, particularly when we overlay pregnancy on top of this, is hand waving and based on case reports and sitting on the MMRC. So overall, in general, fentanyl contamination is driving, there's 67% increase in methamphetamines that have tested positive for fentanyl. We're seeing cocaine overdoses really rise, and they're almost entirely fentanyl related, but methamphetamines are increasing independently. And then when we see the combination of OUD and methamphetamine use disorder, we're seeing really increased rates of death, up to and including 10 times the likelihood of severe maternal morbidity or mortality compared to individuals who have neither of these disorders. And some of that is driven by this myth that methamphetamine prevents overdose, or that folks substitute methamphetamine when opioids are harder to obtain, and then this help me function. But what we think may be happening is that you're getting a combined toxicity and lethality that is exacerbating cardio and pulmonary effects. And when we overlay the physiology of pregnancy and the postpartum period, we are seeing a tremendously higher increase in cardiovascular events. And we're definitely starting to see this as MMRC data is coming in, and we're better at recording what is related to substances. We're really starting to see a pattern emerge that pregnant and particularly postpartum individuals who have a history of substance use disorders, particularly around methamphetamines, may be at increased risk of having cardiovascular events. And so this is a study out of the Utah population database. It really just underscores that when you have that co-occurring opioid use disorder and meth use disorder, they have about a 1 in 5 chance of having severe maternal morbidity, and that's based on the CDC criteria and mortality. And if you have one of those, either opioid use disorder or methamphetamine use disorder, you have about a 1 in 10 chance of having one of these, either severe maternal morbidity or mortality within the year postpartum. And then this is compared to individuals who had neither of those conditions. So in the intro, you heard that I'm on the maternal mortality review committee, and that's a lot of my work is around that. So this is a paper we published out of pregnancy-associated deaths that were drug-related. This paper is from 2005 to 2014, but if I updated it, it would actually be higher. So then a quarter of our deaths were drug-related, and really now we're seeing more like 40% of our deaths be drug-related, whether that be suicide, drug overdose, or some other cause that we think that substance use disorder contributed to the death. And this slide really reinforces that when we are worried about it is that postpartum period. So in our population, 80% of the deaths that were drug related were in that late postpartum period, so 43 to 365 days after the end of the pregnancy, whether it's a live birth, a stillbirth, a miscarriage, or a termination. And then the thing that you see on the slide, the figure on the right side of the screen, is really that it's still certainly being driven by opioids, but polysubstance is really what we're seeing. And that's very similar to non-pregnant individuals, that we're seeing individuals really have either opioids plus some other substance in their system. Often, and about 2/3 of our individuals that died had 3 or more substances. And so this is data actually out of the Arizona MMRC. This is the latest report that has come out. And it looks very similar to Utah. So factors that contributed to death in Arizona from 2016 to 2013. So the orange is all pregnancy associated deaths. So anybody who was pregnant or postpartum up to a year, nearly 4 in 10 individuals had a substance use disorder that was related that was associated with that death. And then pregnancy-related deaths are only those that the committee determines to be directly related to the pregnancy. And fortunately, when we drop down to that low, then you can't report because the numbers get a little bit small.
We've got about 15 minutes left.
Thank you. And so this is this figure, the one on the pink. What's hidden here, and this is what we all struggle with when we're trying to report our data, is that cerebrovascular, coronary, and cardiovascular conditions can include things like amniotic fluid embolism, preeclampsia, eclampsia, and those may be driven by or exacerbated by substance use. So some of these, the mental health conditions, when we report this, we often include substance use disorders in that because our numbers get too small to tease them apart. But there are people with substance use in each and every one of these categories, both in Arizona and in Utah. And what we're seeing this is really what we're seeing nationally. And so this is national data. This is pooled data from multiple 14 MMRCs across the country. And we're seeing this is not an Arizona issue or a Utah issue or even a West issue. And this is really nationally, we're seeing this trend. And the MMRC, the CDC has really started to focus on whether discrimination contributes to death. And there's really more national recognition that the ways in which people are treated, whether that's because of their race or their ethnicity or class or in the insurance that they have or the conditions that they have, including substance use and mental health disorders, may be a primary driver of these increased deaths that we're seeing because, for example, people may have had poor experiences with the medical system, then they delay their care. Once they delay their care, their disease has had, for example, cardiovascular disease may have further developed and become exacerbated, and then that leads them to the path of death. So in the remaining 15 minutes, we are going to cruise through care for pregnant people with substance use disorders. And a lot of this is, evidence informed. I will emphasize that screening is not a UTOX. It's just not. So if you're using UTOXs for screening, it is not an appropriate way to screen for substance use disorders. So really ACOG recommends that we're screening in pregnancy with a validated screening tool within an expert model. And it's often hard to ask anybody about screen anybody for substance use, but it's important to ask. We know that we expect to get our blood pressure taken when we seek any kind of healthcare, and that's really to identify people who are at risk of cardiovascular disease and stroke. And we are not asking in the same systematic way about substance use and substance use disorders, but that is killing far more people, and particularly individuals who are younger every year. So the question that we really need to talk about is my baby going to get taken away, right? The reason, if you're going to screen, people say, well, how do you know if they're not going to lie to you? You don't. You have no idea if they're going to lie to you or not. It's really upon us to ask questions in a respectful way. Respect if someone declines to ask that question, but also have a system of care, because what happens if you just disclose and you don't have a system of care or a way to intervene? It's a gotcha, because what anyone who's using substances is worried about is, are you going to tell CPS, and is my baby going to get taken away? That is the question that pregnant individuals who are considering parenting really want to know. And what we know is that that individuals who are Black, brown, or poor are much more likely to have their babies removed from their custody. And so this is by race and ethnicity, not necessarily around substance use, but we see that reflected in individuals who have their babies removed, their children removed from their custody because of untreated or undertreated substance use disorders. We're really seeing the disparity in Black and brown individuals and those and individuals of lower socioeconomic status. Particularly around UTOX, because this is the talk about pregnancy and parenting, and this is your medical clinicians. UTOX, use with great caution. It's not screening. Providers, including you, I would posit, are terrible at interpreting the results. Maybe the addiction medicine and psychiatry fellows, I might believe that you know how to interpret a UTOX. But in my own department, Terry Kurtz, who's an OBGYN, graduated from our residency and is now about to complete the addiction medicine fellowship. We developed a survey for our own department, and we surveyed folks who either order and interpret maternal or newborn drug testing. And there are questions that people got, and this is my own department, right? These are residents that I have trained. These are my colleagues. These are pediatricians, social workers. There are questions that people would have gotten right if they would have done better if they had just guessed, because we are really that terrible at interpreting UTOXs. So this is my face plant, and I really would caution you that UTOXs should be done. You should really have, if you're going to use them, know why you're using them, what you're going to do with that information. And if the answer is report to CPS, that's not a reason to get it. So what is the best care? So Daisy Goodman published a paper recently on integrated care models versus non-integrated care models. And what we see is that we're actually seeing demonstrable changes in perinatal outcomes in these integrated models. So they saw in their integrated model a reduction in preterm birth compared to non-integrated models. And what I mean by an integrated model is that the addiction and the OB care is happening in the same place. Now, that's in some places, that's not possible. It's just not there yet. So some care, parallel care, is better than no care. We can at least posit that. But in places where we're really seeing integrated care, we're seeing demonstrable changes in perinatal outcomes. And so trauma-informed care really needs to be part of the discussion because of the stigma, discrimination, and just trauma that individuals have experienced who have substance use disorders. And so this is the CDC and SAMHSA have come out with, six tenets of what is trauma-informed care. And really, so it's not trauma care, but it's trauma-informed care. Then you really want to make sure that the care that you are providing provides safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice choice, and is sensitive to cultural, historical, and gender issues. And that these are some of the examples in which you can provide trauma-informed care. So really using that strength-based language. Prenatal, having immediate safety and access to services. Delivery, emphasizing respect and dignity, and recognizing that an individual with a substance use disorder who is pregnant walking into any medical facility has, in general, some trepidation of how they're going to be treated, and if they're going to be treated with disrespect, and if their ability to parent is going to be questioned. And the postpartum period, we really want to keep those dyads together as much as possible and support them long term. So what are the interventions that we want to be focusing on? So I start this part by saying harm reduction, right? So you really want to start with harm reduction, because if that person is dead, right, you can't help. You can't help any other intervention. So it's outreach, education, needle exchange, overdose prevention, access to naloxone, and fentanyl test strips. We often joke, my favorite joke to make about fentanyl test strips is that they are obviously designed by a man, because all women know that 2 lines is positive and 1 line is negative, but it is opposite in fentanyl test strips. 1 line is positive, 2 lines negative. And treatment for pregnant and parenting individuals, women tend to do better in women-specific treatment programs, but there aren't that many of them. And so we really, the best evidence that we have is that those women-specific programs are better, but we don't have enough of them for the need that we have. And they tend to do better when they're able to, if they're trying to parent and they have a substance use disorder, it's either untreated or undertreated, they're able to take children with them. This is often problematic for us when people have older children because they're not often able to take their teenagers. And so that is a huge barrier to women entering into treatment programs. Contingency management, I think, is important to mention because it's one of the highest level evidence of reduction of stimulant use, particularly methamphetamine. But there's, it's often, it's difficult to implement in most programs because it's not funded by insurance. And so we don't utilize it very often because it's often grant funded. And if you get grants from SAMHSA, the amount of if you're using financial motivations, you actually are not allowed to provide enough money to actually get to the dose that people need to be able to get to the reduction that you're trying to see, which is usually abstinence from a certain substance. So for medication for opioid use disorder, you really want to think about it as life-saving. So this is a life-saving intervention. This is a paper out of Massachusetts by Davida Schiff. And what you see is that the orange line, the overdose events are lower for individuals who are on some kind of pharmacotherapy across pregnancy and the postpartum period compared to individuals who are not on pharmacotherapy. And then the figure that you see on the left just shows that there are really significant racial and ethnic disparities between folks who get access to medication for opioid use disorder versus those who do not. And so that really harkens back to that first part of the talk about how we have to really be aware that those disparities have existed and continue to exist today. Medication for method use disorder. This is not evidence, and this is definitely evidence informed. Those of you who are in addiction medicine will know the ADAPT-2 trial. It's bupropion and naltrexone for meth use disorder. It's had a modest response with an 11% improvement in methamphetamine use. There were no pregnant or postpartum individuals that had anything to do with the study. But because often methamphetamine is such a important drug for folks to get to stop using, both for their health of them and for their fetus, but also because of the way in which it is treated by Child Protective Services, we offer this to pregnant individuals to help with cravings. And the idea is that you're helping with cravings. And we've seen modest success with it. And then we're getting to the end. So neonatal opioid withdrawal syndrome, really important to understand. This is a whole nother talk. Excuse me. Best done by a pediatrician, but this is the thing that folks really care about. They want to know, is the medication that I'm taking going to cause my baby to withdraw? So it's really talking about, I often approach it in the way that, and I say, if you had diabetes in pregnancy, the first line treatment is insulin. About 50% of those babies will have low blood sugars, and we treat it with sugar to treat them. And it's self-limiting, and in and of itself does not portend any adverse outcomes for that infant. And NOWS is very similar. About 50% of infants that have either any kind of opioid exposure, but particularly long-acting like methadone and buprenorphine, will experience some kind of withdrawal symptoms. And the best practices are really around providing that care, assessing using, and I'll show you, there's a new paper that just got published about the Eat, Sleep, Console model, and fostering rooming in, which is that process of paired care, and then really continuing that through that 96 hours or however long an infant needs to be inpatient. And so this is a brand new study that was published the New England Journal of Medicine. It was published about 3 weeks ago, well, maybe 4 weeks ago. And it really showed that the Eat, Sleep, Console model was associated with shorter hospital duration for the infant compared to usual care. And there were no differences in adverse events. So comparing 8.2 days versus 14.9 days in usual care when an infant met criteria for being enrolled with, and being medically stable for Eat, Sleep, Console versus usual care. So very quickly, we don't know what we don't know. So there's a lot of what I've presented to you is evidence informed and extrapolated. Are we at time? As I'm seeing you, 1 minute. Okay, so we're doing a bunch of studies. They're hard to do. I made a big deal about progesterone. We're trying progesterone to prevent methamphetamine, return to methamphetamine use disorder. We are enrolling now. Stay tuned. The MOMS trial has concluded enrolling. It's buprenorphine extended release versus sublingual. We're now following MOMS. for a year postpartum using the CAM 2038, which will be marketed, was just approved as Brixadi on the market. And then MatLink is a project that is funded by the CDC, and it's really 7 sites that are doing longitudinal surveillance of dyads affected by opioid use disorder. And we are a site for that. And we're going to be following these dyads for 6 years in order to really provide some of that more high quality data to tell us what happens to these dyads. Okay, we're summing it up. It's a chronic substance use disorder. It's a chronic, treatable medical condition of the brain. Your words and referring to individuals in a person-centered way can themselves be healing. Addictions can hijack that brain, and pregnancy can hijack it back, but beware of that postpartum period when addiction can hijack that brain back. Whenever you are encountering a pregnant and postpartum person, stigma and discrimination are woven into the facets of their experience, and being aware of that and sensitive to that is really important. And treatment modalities are just in general poorly studied in pregnant and postpartum people. So use a shared decision-making model and get comfortable with being uncomfortable with the gray of the data. Okay, that's it. I did not leave much time for questions. I am sorry.
It is okay. It's wonderful to hear people passionate about treating patients with addiction, especially patients that are pregnant or postpartum. I work at the VA. That's a unicorn here. So
they're there. I know we were just joking that some of my colleagues, like the most terrifying thing that we see is we are first call for the VA, and we're all like,
all right. Well, thank you again, everyone. And thank you so much for presenting on this very important topic. We really appreciate your time and your passion for this. For those that are still on the call, if you need that CME credit, it's in the chat, but please text number 926-510. And then the number is 866-327-3062. And we will be taking a little bit of a hiatus. We will be back in August 3rd. So we'll be excited to see everybody in the new academic year.
thank you.
Thank you.
Thank you.